Hello, everybody. Can everybody hear me? Okay, great. So I'm going to start with a story. This is a story of a patient, Mr. T. So Mr. T is a middle-aged African-American gentleman. He works as a custodial worker in an office building. He lives with his wife and 3 kids and is the main breadwinner for the household. He works a full-time job during the week and also works at a gas station to help support his family. He's basically been under fairly good health throughout the years. He hasn't really been following with any doctors. Sort of his schedule doesn't permit it. He has noted over the last few years that his blood pressure has been high whenever it was taken, whether it was at a grocery store or at his workplace. One Friday afternoon, he was walking to his car, suddenly noticed that his right leg gave way. He continued to drive home, was able to drive. Later on that afternoon, he also noticed that while he was trying to pay his bills, he's having difficulty writing the words. Now, he had been pretty tired that day and hadn't been sleeping well over the last few days, so he sort of shrugged it off and thought maybe getting a good night's sleep would make him feel better. The next day, he continued to have symptoms. Symptoms were mild enough that he was able to function and sort of go throughout his day, able to go to the gas station, do his day shift. Then later on that afternoon, when his symptoms continued to persist, he took the advice of his wife, which we frequently do, and was forced to go to the ER. Upon further evaluation in the ER with a CAT scan, Mr. T was found to have an acute stroke. Now, this is not an uncommon case. I'm sure we've all had a patient like this. This was just my patient over the last week. And, whether it's a middle-aged gentleman like this who's very busy to pay attention to his symptoms, has a lot of responsibilities, or whether it's an elderly lady who may not know how to interpret her symptoms and may not want to trouble her family to go to the ER. The point is that public knowledge for stroke awareness remains poor. A study showed that less than 50% of 911 calls that were called within 1 hour of symptom onset, and less than 50% of these calls, patients actually thought they had stroke symptoms. So we're looking at a capture rate of total of 25% of acute patients that we can actually know are having acute stroke symptoms. Intense and ongoing public education has shown to improve recognition. And if you guys could get one thing out of this presentation is, it is our goal, it is our responsibility as healthcare providers to not only to treat our patients with stroke and educate those that have had strokes, but also to provide stroke education to everyone. Because whether it's you who's at risk of having a stroke, it's your father at risk of having a stroke, it's your grandparent at risk of having a stroke, you will encounter somebody who's at risk of having a stroke. And we have, we've made a lot leaps and bounds in terms of treatment, but we really haven't been able to capture the population as we should be. A large registry reported that thrombolytic treatment within 3 hours could be increased from 4.3%, which is our current rate, to up to 29% if all the patients were arriving soon after the onset. This also calls for stroke education campaigns. It's recommended using printing materials, audiovisual programs, lectures such as this, and television, billboards. We want to target patients, caregivers, family members, the whole entire population. Even it's been shown to go out to elementary schools, middle schools, teach patients about stroke awareness. The FAST campaign is a very popular campaign and currently is being recommended by the American Heart Association. Basically, it's F is for face. You ask the person to smile. Do they notice a facial droop on one side? A is for arm. Ask them to lift up their arms. Does one side fall down? Speech, their speech sound slurred or strange? And T is if they observe any of these signs to call 911 immediately. This I got directly from the National Stroke Association website. They have brochures, posters that are, a lot of them are for free or at minimal cost that can go into any hospital or a doctor's office for patient education. Okay. So basically what I'm going to talk about in this presentation is there's a lot of recent stuff that came out with stroke. The brand new guidelines that focus on the early management of patients with acute stroke came out in January 31st, 2013, and late-breaking trial results also came out in International Stroke Conference, which was in February of 2013. And this was interesting because it really actually changed the way we were thinking about a lot of the stroke data up till now. I also want to emphasize the CPOE. Now CPOE has gone live, also known as counterproductive order entry for stroke orders. And stroke. We're also going to talk about the stroke core measures and overall go over the stroke program goals for 2013. So, the good news first, stroke is no longer the third leading cause of death. It is now the fourth leading cause of death as of 2008. And we think this is because it's mostly because what we're doing in the hospital setting. Patients are more commonly going to hospitals that are used to treating acute stroke. There's increased utilization of TPA. People are using evidence-based medicine, using core measures, looking at core measures, following Get With The Guideline programs and the Joint Commission program. There's also increased prevention and improvement in prevention in stroke. But the facts still remain. Approximately almost 800,000 strokes will occur this year. There will be one occurring every 40 seconds. And every 4 minutes they will take somebody's life. Hopefully that will not occur during this hour, because I'm still on call. Risk of recurrent stroke after a first stroke is 30%. So if you've had a stroke, there's a 30% risk that you will have another stroke within the 5 years, and 18% of these strokes will be fatal. There's estimated 7 million stroke survivors in the U.S., and it's also the largest cause of disability in the United States. Stroke serves a heavy burden for the healthcare system. Direct and indirect cost of stroke was $73 billion in 2010, and a mean lifetime cost of ischemic stroke is about $140,000 in America currently. So in order for us to figure out how to improve stroke, we first have to understand the stroke continuum, which is basically multifactorial and based on different entities that interrelate with each other. So it's not that we're just focusing on the acute stroke. We also have to focus on stroke awareness and stroke recognition, because only when we improve this will we be able to capture more patients for acute stroke. And same thing for only improved acute stroke care will improve patient outcomes in the inpatient setting as well as the post-stroke recovery setting. So in order for us to make any meaningful change and difference, we have to focus on each and every one of these factors in conjunction. Stroke management doesn't start in the ER. It starts actually before the ER. With the EMS systems that are in place, they should be able to provide the highest level of care in the shortest possible time. Same goals that we aim for in trauma and myocardial infarction, we have to aim for in stroke. Basically, that means call to dispatch goal is less than 90 seconds. EMS response time should be less than 8 minutes. And there should be somebody on the scene in less than 15 minutes. Rapid evaluation should be done. First, stabilize the patient. It's important to emphasize the blood pressure management parameters that are important for stroke patients, which are different than other patients. Treating hypoglycemia if it's present, a quick neurological evaluation using stroke assessment tools such as the Los Angeles Stroke Screen and the Cincinnati Stroke Scale. Now these have been very sensitive and specific in detecting acute stroke based on patient symptoms, and transport the patient to an acute stroke center. One of the things that we're stressing EMS do is also to obtain an accurate last known well time, because that's the most important piece of information that we use for the ER. And to encourage bystander or witnesses to come with the patient, because a lot of the stroke patients who have severe symptoms may not be communicative or may have a significant aphasia, which may impede them from giving information. It's also important to encourage the EMS to call the hospital to notify them that they're bringing the patient over, because this will also cut down the amount of time that it takes for us to evaluate the patient. And the patient should be brought to a primary stroke center. The main reason for this is because primary stroke centers have higher rates of giving TPA, and which essentially leads to better patient outcomes. They also have multidisciplinary quality improvement committees to track key quality stroke core measures. They track the time it takes the patient to see the physician, the door to CT time. Goal of IV TPA time is less than 60 minutes. They also had improved prevention measures, more lipid profile testing, and improved DVT prophylaxis. It's been shown that for every 15 minutes reduction of door-to-needle time, lowers the odds of in-hospital mortality by 5%. Telemedicine is more commonly used now for stroke, and I apologize, I couldn't find a better picture than this. It kind of makes the person look a little evil, but we use it here. The benefit of telemedicine is gives immediate access to the neurologist. You can have reliable neurological exams and assessments, high rate of IV TPA with low rates of hemorrhage, which is what we want. And functional outcomes of IV TPA, the data nowadays is showing that it's more similar to what's been shown in the randomized trials. And telemedicine in conjunction with stroke education for the training of healthcare providers can be useful in increased use of IV TPA in the community hospital setting as well. One of the things that we do here is we collect data. We track all specific times, which is why it's important for us to adhere to the stroke core measures, because people who do this, the hospitals that do this will have better patient outcomes, because we're actively participating in patient quality initiatives. Like I said, we track the TPA time, We make sure the prevention measures are done, including antithrombotic within 48 hours, DVT prophylaxis, anticoagulate for patients who have AFib, treat for LDL greater than 100, smoking cessation counseling as well. As the patient comes into the ER, because we have such a narrow time window, makes the evaluation and diagnosis even more important. This is, on the right, is sort of the goal that I've come up with for the new stroke protocols that we're working on. Basically, within 10 minutes, we want the patient to be seen, to have the last known well time confirmed, have the initial NIHSS evaluation, and to be evaluated for any contraindication for IV TPA. So we have basically gathered most of the information we need to determine if patient needs IV TPA within the first 10 minutes. Within 25 minutes, patient should have a head CT. Weight should be determined for accuracy for dosing for IV TPA. And if, based on the head CT, if the patient is determined to be considered for IV TPA, pharmacy should be called immediately, and blood pressure measures should be put into play for those patients that are candidates. Currently, we're recommending Cardene drip, and the goal of, it's not blood pressure more, that's an error, less than 185 over 110. And the goal of IV TPA is within 60 minutes. Okay. When we're evaluating the patient in the ER, we want to not only gather this information. Yeah. So if a patient is, I'll get into this a little bit more later, but typically stroke patients have high blood pressure when they present. And it's more or less a compensatory mechanism from the stroke. The TPA guidelines require the patient's blood pressure to be less than 185 over 110 in order for us to be able to give TPA. And the latest data suggests is Cardene is probably the best agent to use in that setting because it allows us to put them on a drip quickly and sort of manage them below that pressure without dropping it completely too low. So that's what we plan to put into the stroke protocol. So, does that answer your question? Yes. Okay. All right. So it's not only important for us to treat for a stroke, we also have to exclude there are certain, if there's any stroke mimics, because certain other condition will present similar to a stroke. And it's part of the neurologist as well as the ED doc's evaluation to determine if that's the case. The last known well time is very important, and a lot of times things happen when you wake up in the morning. So you have to sort of do some creative questioning. What time did the patient go to the bathroom at night? Sometimes it's also even helpful to look at their cell phone logs. Nowadays everybody's texting, so that's one of the things you can use to see if they texted anybody before then, if they're not able to give you any information. The other important key point is that if a patient presents with symptoms, neurological symptoms that resolved and then started again, that basically resets the time clock. So basically, if you had weakness yesterday, you didn't have weakness this morning, the time clock for TPA starts when you started having weakness again this afternoon. Okay. Physical exam, you start with the ABCs. You do a brief but thorough neurological assessment with the NIHSS score, which is basically a total of 15 questions, and should be able to be, full neurological evaluation should be able to be done within 4 to 5 minutes using this. And yes, there is an app for that. Nowadays, it's readily available for anybody to hold the NIHSS score within the grasp of their hand, their cell phone. This is the new stroke protocols that we're working on. The things that I'm trying to emphasize is on the left, top left, you'll see that the times, we're trying to be more focused on tracking the time for basically every stroke alert that's called in the ER, all the way from patient arriving to when the TPA was given. We're also looking at the modified Rankin scale, which tells you how the patient was at baseline before. So if they're non-ambulatory and bedridden, giving them TPA is probably not going to do too much for them anyways. So it's important for us to track this as well. And the NIHSS stroke scale, if a patient gets TPA for the first 2 hours, it has to be checked every 15 minutes. And then every 1 hour and so forth. Every half hour, then 1 hour and so forth. We're also looking at any delays. If there's any delay, why did the patient get delayed from receiving TPA? It's important to mention stroke mimics because we've all seen them. These are just a few. There's a much larger list. Probably the most common ones here. Conversion disorder. These patients can show up with weakness of the arm and leg, but may not have any cranial nerve findings, which should correlate with that. The neurological finding may be non-vascular in nature, so it may be like numbness of the arm but sparing the hand. Hypertensive encephalopathy presents with headache, delirium, significant hypertension, cerebral edema. Also, same thing goes here. The findings may not go into a specific vascular distribution. Hypoglycemia can many times mimic a stroke, and it's very treatable. However, it's also important to know that if hypoglycemia occurs for a long enough time, it can actually cause an acute infarction. So we want to be proactive about treating that. Complicated migraines is kind of tough because these patients can look exactly like a stroke. What we want to really distinguish them is whether they've had similar events in the past, if it preceded by an aura or a headache. Seizures can show up like a stroke with Todd's paralysis. You want to think about any history of seizures, witness seizure activity that was seen, or if the patient was in a post-ictal state where they were confused and sort of doesn't really fit together with the picture. But this is a little bit of our saving grace for neurologists. There was a study done, part of a registry, which was retrospective analysis, but it was done with 512 patients who were treated with IV TPA for less than 3 hours. After the fact, it was found that 21% of these patients were actually mimics. They weren't real strokes, largely comprising of seizures, complicated migraines, and conversion disorder, and none of them had a symptomatic hemorrhage. So basically, we think that's the reason that they didn't have any hemorrhage is probably because they didn't have a real stroke. So there was nothing to cause a hemorrhagic conversion. So the basic thinking now is that we want to treat patients. If we're not sure, we should go more towards treating them with IV TPA rather than not giving them the medication. Testing in the ER, we check blood sugar, electrolytes, renal function, basic testing. In select patients who are, this is new in the guidelines, who are on factor 10 direct thrombin inhibitors, the newer agents for treatment of AFib, one of the options is to check their thrombin time or ECT, which is eccrine clotting time. And if this is normal, they should be able to get TPA. However, I don't know how useful this is for us at this junction because I'm it takes a long time for these labs to come back at this point, and a lot of hospitals don't even have them available. So maybe in the future this can be used. In certain patients, you want to consider pregnancy test, UDS. But it's important to mention, if the patient is not on a known anticoagulant or have florid liver function, dysfunction, the only lab test you really need to check is the blood sugar. Everything else has to be checked, but you should not slow you down in terms of treatment. Same thing with the EKG. EKG is recommended, but should not delay treatment as well.
So, Raj, if somebody comes in now with on a direct thrombin inhibitor, what's your recommendation?
You can't treat them because there's no way that we know to reverse it, and right now, at least in our hospital, we have no way of checking it quickly. So, neuroimaging. Non-contrast head CT is sufficient for the identification of contraindication of TPA. Exclusion for IV TPA include intracranial hemorrhage, or if the CT shows just diffuse hypodensity, hypoattenuation in a specific vascular distribution. Early signs of TPA include hyperdense vessel sign, loss of gray-white differentiation, loss of insular ribbon. And it's important to mention that these early signs are not the same thing as the hypoattenuation. So just because you see the early signs should not stop you from giving the medication. If there is a clear hypodensity or mass effect seen, it's been shown that it has an 8-4 higher risk of hemorrhage. So we really don't want to give these patients TPA. MRI brain is very good, very sensitive, specific for detecting acute infarction, and it can also figure out if patient is having a stroke within minutes, but has limitations. The biggest of which is it just takes too long. It's not available immediately. If patient has a pacer or implant, they might not be candidate for it. They may be claustrophobic. So,
question on the CT.
Sure.
What is the incidence of false negatives when you actually are having a stroke and it's read as a normal CT scan?
very high, because in the early parts of a stroke, you will not see changes on a head CT. They say almost up to 6 hours. But this is where this early signs can sort of help you as well, because if you're seeing a hyperdense vessel lesion, you may know that this patient's having a large vessel stroke.
Well, that's where I'm going with this, is you have a negative CT scan, a patient who may be having a TIA versus a early stroke. Would you go ahead with the TPA with a negative CT scan?
Absolutely, because the CT scan is only done to rule out any exclusions for TPA. So if they don't have any exclusions, they are candidates for TPA. So.
Well, let me take the next step, because insurance companies all kind of believe TIA should be kept for a while and sent home the same day. What is your perspective on handling TIAs? Do you prefer to admit them, or again, are you going to acquiesce to the standards set by the insurer?
So there have been some papers out looking at this specific thing, and other large university hospitals have come up with protocols how to determine which TIAs stay and which TIAs can be followed up. There have also been a lot of places, mostly in Europe, that have instituted TIA clinics. So basically, this is a clinic run by a neurologist or a vascular neurologist, and the patient gets the studies done and evaluation done fairly quickly as an outpatient, and is seen by the doctor the next day or the following day. So that's something that's a big debate, and in the States where we tend to be quite conservative before making any changes to the healthcare system. But there will be, I think that's something that's in the future. So early signs of stroke on CT. Here you can see a hyperintensity at the area of the left middle cerebral artery. This is indicative of a hyperdense vessel sign showing a thrombus in the artery. Here you can see loss of gray-white differentiation. I don't know, it's not very well seen here in the, if you can take my word for it. Loss of gray-white differentiation in the subcortical structures of the brain. This is indicative of an early sign of a stroke. Here's another hyperdense vessel sign in the sort of the Sylvian fissure near the insular area. So TIA, this gentleman asked about. So the other thing to remember about the TIA definition as we know it has changed. So TIA is no longer based on time, whether it's 3 hours or 24 hours. Now it's a tissue-based definition. What basically that means is they took a whole bunch of patients who had TIAs, they did MRIs on everybody, and found that half of them actually had strokes on MRI. So 50% of TIAs are actually found to have strokes, and therefore they felt that they were looking at TIAs the wrong way. And in fact, patients should get neuroimaging to confirm whether they actually had a stroke or not. Vascular imaging is also recommended, including a CTA or MRA for head and neck to assess intracranial and extracranial circulation. So once the initial IV TPA evaluation is complete, and whether the patient is determined to get the TPA or not get the TPA, they should all get a vascular imaging in an acute basis. And again, we recommend CAT scan, CT angiogram because of the quickness and relative good accuracy in terms of determining if there's a large vessel infarct. Because patients who have a large vessel infarct, including MCA, basilar artery occlusion, distal ICA occlusion, may be candidate for IA TPA and intervention with mechanical thrombectomy. Of course, the disadvantages include the IV contrast you have to give, the additional radiation exposure. And some patients may not be a candidate for this. Here is an example of a CTA showing an abrupt cutoff at the left MCA. I'm sorry, the right MCA here. And the other thing that you can also appreciate is the hypoattenuation of the vessels on the right side compared to the left side, all indicating that this patient is having a stroke. So somebody like this may be a candidate for more than IV TPA. Maybe they want to put a catheter in him, give him IA TPA, or use one of the new devices to take the clot out. CT perfusion is another newer study that's being used fairly commonly within comprehensive stroke centers. It takes the cerebral blood flow, mean transit time, and cerebral blood volume, and basically tells us if there is a penumbra or actually tissue that's salvageable and whether this patient will benefit from getting further intervention. There has been a lot of questions whether using the CT perfusion is the right thing, and this is another thing that the recent trial results have sort of shown. Maybe there's a lack of efficacy, and maybe we're sort of looking at this the wrong way, and I'll talk more about that as we get into it. So this is an example of a CT perfusion study. This is a cerebral blood flow, cerebral blood volume, and an MTT. So MTT is the most sensitive at finding if there's evidence of ischemia. The cerebral blood flow will also show, should be compared with the MTT to determine the area that's involved. And the cerebral blood volume is showing, in this example, showing a smaller area of that's basically is the core infarct. and this larger area is the area that is showing lack of perfusion. So you compare this study with this study, so you have a smaller core infarct and you may have a larger area that's at risk of stroke or maybe salvageable tissue. So while in the ER, all patients should be put on O2 sat to maintain SATs greater than 94%. Their bed should be put at 30 degrees to prevent the risk of aspiration. If they're hypothermic, this should be treated because it is it's an indicator for poor prognosis for stroke. There is some data, mostly from Europe, showing that induced hypothermia may be neuroprotective and may give you maybe a prolonged time for treatment. However, this is still requires phase 3 trials, maybe something that may occur in the future. Cardiac monitoring is recommended to screen for AFib. Blood pressure management. Like I said, blood pressure is often high after a stroke, and this is a compensatory mechanism. The body has to provide the brain with perfusion. Again, patients who's getting a TPA, their blood pressure has to be less than 185 over 110, and we're recommending using Cardine drip at this point. Acute strokes who do not receive TPA, we allow for permissive hypertension, and again, this is to maximize cerebral perfusion, so blood pressure should be allowed to go as high as 220 over 110. Restarting their blood pressure medication is reasonable if they've been stable for 24 hours without any neurological changes, and we recommend a gentle reduction of 15% per day. Right now, we have no clear data to guide us exactly what medication is best for lowering blood pressure. Hypoglycemia should be corrected. If the hyperglycemia is persistent over 200 for the first 24 hours, it's been associated with worse outcomes. We want to be sort of reasonable at treating hyperglycemia and try to aim for a blood sugar of 140 to 180. Aggressive management of hyperglycemia has also been shown to show poor outcomes. IVTPA, again, I'll review the NINS trial, which was in 1996, which changed all the lives of all neurologists out there. It showed excellent outcomes on multiple measures with TPA than without, including global disability, global outcomes, activities of daily living, and neurological deficit. The major risk factor still remains symptomatic intracranial hemorrhage, which is 6.4% based on the NINS trial. Again, presence of cerebral edema and baseline head CT was associated with higher risk of symptomatic hemorrhage and should be avoided. And presence of early signs of stroke is not associated with a higher risk of hemorrhage. A large registry looking at almost 12,000 patients who are treated with TPA less than 3 hours. This came out in 2009, and among this large group of patients treated, the actual symptomatic hemorrhage risk was significantly less than what the NINS trial found, was 1.6%, and the frequency of favorable outcome at 90 days was almost 60%. So confirming the efficacy of IVTPA. Off-label use has been discussed, and there have been several trials over or studies over the last 2-3 years, and the data is suggesting that IV TPA is probably safe in patients who have extreme age. If patient has had a stroke and has diabetes, it's probably safe. Even if patient has a minor stroke, they have been found to have benefit from getting a TPA. If patient's having rapidly improving symptoms, if the symptoms have not completely resolved, they can still get TPA. And this was the most recent thing, which showed that if they have recent MI or major surgery preceding 3 months, they are okay to have IV TPA. Overall, treatment was better than not getting treatment. The IV TPA time was extended to 4.5 hours after the ECAS-3 trial. Still showed that at 90 days they had better outcomes. Symptomatic hemorrhage risk was quite low here too, 2.4%. And in this, there were several exclusions, including age greater than 80, NIHSS greater than 25, history of stroke and diabetes, and if patient is on an anticoagulant, even if their INR is normal. This is not approved by the FDA, but it is recommended by the American Stroke Association, American Heart Association. Combination of IV TPA or IA TPA, also known as the drip and ship model, basically where we give the patient IV TPA when they present and then ship them to a comprehensive stroke center to get IA treatment is basically considered safe as well. And actually, some studies have shown that giving them IV TPA actually may decrease the time it takes for the mechanical thrombectomy. Anticoagulants, currently we do not recommend the use of any anticoagulation such as heparin drip with the goal of halting neurological deterioration because of the higher risk of hemorrhagic conversion. If you feel that the patient had a stroke from a clear cardioembolic source, it is still not recommended that we start them on urgent anticoagulation because we feel that the risk of probably embolizing while we get them going on Coumadin is relatively low. What I tend to do in most of these cases is if I know the patient is stable, within the next day or so, I will start them on aspirin. Aspirin will be started within 48 hours and eventually just bridge them on to Coumadin. In stroke patients, hypovolemia should be corrected with normal saline. Volume expansion, unfortunately, has not been shown to reduce mortality. Our goal is to aim for euvolemia. Vasodilation was looked at. This should not show cause any difference in outcome. Induce hypertension using pressors, particularly phenylephrine, is not recommended currently not recommended in the setting of acute stroke. However, even though there's no clear criteria, we do recommend blood pressure augmentation if the patient has a large perfusion deficit, has a compromised blood vessel, or demonstrate neurological changes which correlate with their blood pressure. So if their blood pressure is dropping and they're becoming weak, we will start them on, if need be, vasopressor, or the phenylephrine to improve the pressure. Urgent CEA is currently not recommended for unstable patients. We feel that the risk has to be balanced with the risk of neurological deterioration on medical therapy. So first, we recommend medical therapy because there's a high risk of complication on those patients that get CEAs and in unstable. nature. Patient should be admitted to the stroke unit. If the patient is suspected to have pneumonia or UTIs, they should be treated with antibiotics. If a patient with a stroke gets pneumonia, their mortality risk is pretty much tripled. So we want to be first very aggressive about preventing it with the aspiration precautions. Basically, every patient who comes in through the ER has to also go through a dysphagia screen prior to being initiated on any oral intake, which is followed then by a assessment by speech and swallow. Early mobilization for less severely affected patients is recommended. Routine placement of indwelling catheter is not recommended because of the risk of UTI. Cerebral edema. In all strokes, cerebral edema occurs, maximum occurring within 72 hours. So the first 3 days are the most important, especially for the large infarcts, particularly those patients that present with strokes in the posterior fossa involving the cerebellum have to be watched very closely because they tend to decline very quickly. Those patients who are at risk of malignant brain edema should be transferred to an institution with neurosurgical expertise. Corticosteroids are currently not recommended due to lack of their efficacy and the risk of infectious complications. So management of edema, medical management, we recommend restricting any free water, hypoosmolar fluids, avoid excess glucose administration, minimize any hypoxemia or hypercarbia, and treat hyperthermia. Also, it's recommending to keep the bed, head of the bed at 30 degrees to maximize venous drainage. Increased ICP. This can be seen in patients who have large infarcts or large hemorrhages, particularly in subarachnoid hemorrhages. Basically, if patient is having prolonged increased intracranial pressure, they will need some type of a surgical procedure, whether it's a decompressive surgery or an interventricular drainage if they have developed hydrocephalus. There are measures that we can use to decrease ICP medically, such as hyperventilation, which has been shown to be effective in decreasing the intracranial pressure. However, it's not, usually it only lasts for a couple hours before the body compensates for it. The other thing that we use is hypertonic saline or mannitol use, which has also been effective in decreasing intracranial pressure. However, this should also be used as almost a bridge towards getting them to surgery. Large studies have shown that overall, just use the mannitol alone does not decrease patients' mortality. Okay, I'm going to briefly talk about secondary stroke prevention. This was not something that was mentioned in this guidelines, and really only a couple things have changed in the last 2-3 years. For hypertension, 72 million Americans have hypertension, which is defined as systolic blood pressure greater than 140 over 90. Meta-analysis of a randomized controlled trial have shown that improving their blood pressure, you will drop their risk by 30 to 40%. And the better you are at reducing their blood pressure, the better you do in terms of reducing their risk. And right now, we don't have any clear evidence of which drug class specific treatment for stroke. Diabetes affects 8% of the population. Prevalence is 15 to 33% in patients with ischemic stroke, especially those that have small vessel strokes. And the recurrent predictor for those with small vessel stroke is 9.1% if they have diabetes. Diet, exercise, oral hypoglycemic drugs, and insulin are recommended to gain glycemic control. Lipid goals, basically, we recommend treating anybody with LDL greater than 100 with statins. If they have diabetes or their stroke is not deemed to be secondary to cardiac cause, you can aim for a goal of less than 70. Another important thing that should be mentioned is low LDL has also been shown to have a greater risk of intracranial hemorrhage. So if patient presents with a hemorrhagic stroke, you do not want to readily maximize their statin use, because there is a small risk of causing a recurrent hemorrhage in them. If patients have low HDL, they should be treated with niacin or gemfibrozil. Carotid stenosis and CEA. So basically for a symptomatic severe stenosis, CEA is recommended. And for those with moderate stenosis, 50 to 60% in select patients, depending on their comorbidities, CEA is also recommended. When the degree of stenosis is less than 50%, we recommend medical management only. And basically, if a patient presents with a TIA or stroke, it's surgery should be aimed for, and we think if it's a symptomatic stroke, surgery should be aimed for about 2 weeks. There have been a lot of data over the last couple of years that came out about carotid angioplasty and stenting, particularly the CREST trial, which is the largest trial looking at stenting versus CEA. So just to talk about stenting, it has advantages. It's less invasive. It causes less patient discomfort and has a shorter recuperation period. And overall, for mortality or risk of major stroke after CEA or stenting, there's no difference between surgery or stenting. However, in the CREST trial did show that mainly for patients who are older than 80 years of age, there's a higher risk of complications, up to 12.1%, compared to those less than that. 79 is 5.3%, and much less age less than that. Again, there's no long-term difference between the two, but short-term, within a month, angioplasty has shown a higher risk of mini stroke or minor stroke, whereas CEA has a higher risk of myocardial infarction. Antiplatelets, basically the guidelines, the studies have all shown to contraindicate the study done previously. So the guidelines now recommend use of any one of the three main antiplatelet medications that we have, including aspirin, Agranox, and clopidogrel. For patients who are allergic to aspirin, it's recommended that they go on clopidogrel. So, we went to the sunny Hawaii for the International Stroke Conference in February. However, what we got was not so sunny results. So there were 3 main trials, which I'm going to go through, looking at endovascular treatment versus IV TPA. The first one was the IMS-3 trial. This is a phase 3 randomized, open-label, international trial comparing the use of IV TPA and IA TPA compared to just IV TPA alone. 656 patients were enrolled. Endovascular therapy included a choice of catheter or devices, so this included IA TPA plus mechanical thrombectomy with all different devices, from using the Mercy retriever device all the way to the most recent Solitaire device. And basically there was no benefit of IA TPA with or without mechanical thrombectomy over just using IV TPA alone in all different vessel distributions. There was also no difference in safety, including hemorrhage rates or mortality amongst these groups. The main reason that people are saying that this might be the case was because the average time it actually took for a patient to get treated was around 6 hours after symptom onset. This is most of the patients that were treated at Comprehensive Stroke Center. And they did a sub-study analysis which showed that every 30 minutes that passes until the patient has angiographic reperfusion, the probability of good recovery decreases by 10%. The next trial was the MR Rescue trial, which was a phase 2B multi-center controlled blinded outcome study, randomly assigned 118 patients within 8 hours of onset of a large vessel anterior circulation stroke to get either mechanical embolectomy with the Mercy retriever device, which is sort of like a corkscrew device to retrieve the clot, versus the Penumbra system, which is more of a suction type device. All patients underwent CT or MRI prior to the treatment, and this is where they looked at that CT perfusion or MR perfusion. Whether to see if they had any favorable penumbral pattern. So if the patient had the favorable pattern, they were treated. If they didn't, they were held from treatment. And this basically showed that identifying a favorable penumbral pattern on imaging did not help us select the patients that would preferentially benefit from endovascular treatment up to 8 hours. So basically it showed that a patient who had a large penumbra on the CAT scan did not benefit from it. And now that and actually, I didn't mention this in the result, but actually patients who got just IV TPA with large penumbra, didn't forego the treatment, tended to do better. So actually what it's saying is the way that we're thinking of the penumbra, the salvageable tissue, may be different, and the fact that this is not something that's salvageable tissue at risk, but instead it's tissue that may have a better outcome because of better collateral circulation. Sort of 180 degrees of what we were thinking. And the last one was the synthesis trial, which looked at IV TPA versus IA TPA at 3 months in terms of outcomes, and there was no benefit of IA TPA thrombolysis. So conclusion of all this is basically IV TPA is still the first line treatment. If patient is a candidate for it, should receive IV TPA, and we have a big responsibility as primary stroke centers to take care of these patients, because we're usually the first people to see it. Lastly, the CAT study is a prevention study. It was done in China, looked at a large amount of patients, 5,000 patients. compared aspirin, 75 milligrams for 3 months, versus combination of aspirin and Plavix. These patients were loaded with Plavix, and the majority of these patients were with TIA or minor stroke patients. And basically, they found that a short-term combination of aspirin and Plavix showed 23% relative reduction in risk of ischemic stroke, and there were no increases in major hemorrhages or myocardial infarction. So maybe combined aspirin and Plavix may be beneficial for a short term after a minor stroke. There's CPOE order set shows there's new stroke order sets. Few things that I want to sort of emphasize is stroke patients should be going to the stroke units in Camden, in CC1, in PCU, or 3 East, depending on their condition. Neurology should be consulted. Stroke coordinator, physical therapy, occupational therapy, and speech therapy should be consulted in all TIA and stroke patients. Labs, fasting liver profile, hemoglobin A1C, urine drug screen if the patient is less than 50 years old. DVT prophylaxis is important. Blood pressure medications, we want to emphasize allowing for permissive hypertension, and patients should not receive blood pressure medication who have not received TPA up to a blood pressure of 220 or 120. Diagnostic testing including 2D echo, carotid ultrasound, and MRI, MRA. So specifically I want to mention about MRI, MRA. If you think the patient had a stroke, most likely, or TIA, they will need an MRI or MRA. So you don't have to wait till the next day for the neurologist to see the patient. You can go ahead and order it to get the ball rolling for the patient. NIHSS score for TPA patient, we mentioned this already. One of the things I want to mention about the TPA, patients who get TPA, in the order set, there is nothing written about restarting them on antiplatelets after the 24-hour period. So it is your responsibility to make sure they get a CAT scan 24 hours after the TPA, make sure they're started on DVT prophylaxis and antiplatelet medication after 24 hours post-TPA. Swallowing, we spoke about that already. When discharging the patient, please address the stroke core measures. It's very important. We are doing all of these things listed here. However, we're not documenting them, so this is not giving us credit in the eyes of the Joint Commission. So it's very important for you guys to, when discharging a patient, go complete the stroke core measures. Unfortunately, it's not a mandatory core stroke measure, so you can discharge the patient without completing them. So it's your responsibility to make sure this is done. Basically, we want to provide comprehensive stroke care as much as we can. Basically, going back to that stroke continuum. We're working on new protocol for EMS, for the emergency department, for the ICUs, for the stroke unit. We're also working on doing daily stroke rounds, which are multidisciplinary rounds, which I carry out every day on the stroke unit. We're working on an inpatient acute stroke protocol, a particular stroke alert system, which will replace our current RRT stroke protocol. We are looking into the rapid TIA inpatient assessment and observation unit. That's something I'm working on Al with, and possibly doing what this gentleman suggested, is basically doing a rapid evaluation in the ER for patients who may not need to be admitted. Discharge planning, we're calling all the patients who have a stroke or a high-risk TIA, or who may have, within 2 days to get, make sure all the services are within place and they're getting stroke follow-up in our stroke prevention clinic within 2 weeks. The stroke prevention clinic is something that I'm running on Fridays afternoons. It's a unique service. Nobody else in the South Jersey area is doing the clinic catered to stroke. Basically, we help the patient create an individualized stroke prevention plan for them, give them resources, assisting them in controlling risk factors, smoking, diabetes, weight loss, nutrition. So if you have any stroke patients, who you believe at higher risk, you can feel free to refer them to me. Okay? Working on data collection initiatives, education for the entire hospital, basically. And I'm going to leave you with the stroke continuum again. Basically, it's up to us to work on everything if we're going to make a difference. Okay? Thank you very much.